Είναι ιδιαίτερη τιμή για μένα και για το ΙΑΣΟ, πιστεύω, η παρουσία του Professor Andrew Gennery, who is Paediatric Immunologist, who works mainly with transplantation for pet patients, inborn error of immunity, and we are happy to have a so interesting subject that it is the effects of the microbiome on immune dysregulation. Thank you very much, Andy, for coming into Athens and GSO Children's Hospital, and we are looking forward to your lecture. Thanks a lot.
Thank you very much, Maria. Kalispira. Sadly, that is one of the very few words of Greek that I know, but maybe I need to learn more. Thank you very much for the invitation. I have a slight confession. So I was invited to speak at the Espid meeting, which is in Athens at the moment, on a topic that was not so interesting, but it was an opportunity to come to Athens for 5 days, and the conference would pay for me to go and to stay, and who wouldn't come to Athens for 5 days? I thought actually I would have the opportunity to take 4 days to wander around Athens and enjoy the sun and the food and see all the sights. I have known Vivian Magina for now 10 years or so, and she said, oh, well, whilst you're here, maybe you could give a talk. So I've not been quite as relaxed as I thought I might be, but it is a real privilege and a joy for me to be here today. So thank you for asking me. So I'm going to talk about the effects of the microbiome on immune dysregulation. I thought we might start, and apologise if I get these pronunciations wrong, but I thought we might start with Aristarchus of Samos. I'm sure you all know much more about him than I do. His only book or piece of writing that is still available is on the sizes and distances of the sun and moon. Actually, he got that wrong. However, he did write another book which has been referenced by Archimedes. And in that, Archimedes said that Aristarchus has brought out a book consisting of certain hypotheses, that the universe is many times greater than the universe that had just been defined, and the fixed stars and sun remain unmoved, and that the Earth revolves about the sun on the circumference of a circle, the sun lying in the middle of the orbit. Sadly, it was another 1800 years before the rest of the world cottoned onto that with Galileo, and of course, whilst we don't entirely agree with that description, he was certainly ahead of his time. I'd like to show you one of my favourite photographs. I don't know if Vivi will remember this. I think we may have talked about it when you were in Newcastle 10 years ago. This is a picture taken by the Hubble Space Telescope. Actually, it's not a very interesting picture. This was a picture, I think, released at the end of 1995, and it was the result of 11 nights of the telescope gazing at this very dark spot in space for 11 nights and just collecting light from that very dark spot. In terms of how big that spot is, I'm told that if you took a tennis ball and put it 100 metres away, the arc between you and that tennis ball would be the area that it was focusing on. So a really small, dark area of space in which there was nothing. Except that wasn't true. These aren't stars, these are galaxies. So in that dark area of nothing, it's actually full of galaxies. I think that is absolutely amazing. And we are just kind of at the beginning of the journey of working out what that all means. I think that's probably true for the microbiome. This is a stromatolite. It's a fossilized web of bacteria, of cyanobacteria. I think this one's from Australia, and it's about 3.5 billion years old. I think they have found some that they believe might be about 4 billion years old, made by cyanobacteria. Now, for those of you who are interested in geological time, we tend to concentrate, see if I can get this right, on this period of time, the Phanerozoic, because it's when there's the most interesting life around, and there's complex life, and we get excited about the blue bit, because that's when the dinosaurs were around, and we get very excited about this bit up here, because that's when we arrived. The problem with this sort of geological time scale is it condenses this bit. Unfortunately, the thing that we think is most interesting makes up 12% of the Earth's age. So if you put that into some sort of context, that not very interesting red bit is all of this, and the bit that we get excited about is this. We think that bacteria may have started on Earth. Here is the beginning of the Earth, and bacteria may have started somewhere around here. And we appeared somewhere around there. So there's a bit of a discrepancy. This would be another way of looking at that time scale. So we've got the formation of the Earth here. We're beginning to get maybe single-cell organisms here. Bacteria probably arrived somewhere around here. And for those of you that are interested in immunology, the adaptive immune system, which of course is the most interesting part, arrived here. So it's actually pretty young in terms of age of the Earth, but it's also pretty young in terms of living things, except that we have forgotten most of those living things. The cyanobacteria, which were probably some of the first things that ever formed on Earth. We're a bit human-centric, so we concentrate on that and kind of ignore perhaps one of the more important things. I don't know which this word is referring to. I don't know what they are, but they're keeping up with us. Or maybe it's the bacteria saying, I don't know what they are, but we're keeping up with them. They have been around an awful lot longer than we have, and therefore it's perhaps not surprising that they have more of an influence on us than perhaps we have on them. And I think we're only just beginning to unravel some of that influence. When we look at the kinds of cells in the human body, it's a little chastening to realise that we're only 25% human. We've actually forgotten the virome in here. We've got the bacteria and the fungi, but a significant part of our microbiome is also viruses as well, and I was learning about some of that in the Espid meeting yesterday. I did actually go one day. When we look at humans versus just bacteria, the number of cells of bacteria outnumber us 3 to 1. When we look at our genes versus the microbial gene load of the microbes that we carry, we are outnumbered about 150 to 1. And it would be bizarre to think that that gene load that we carry is of no consequence whatsoever. You could argue that we are one of the most complex microbial ecosystems on the planet. Maybe that's taking too much of a human-centric view again. Actually, we have many microbiological niches, and they are different. So the kind of microbial flora and patterns that we find in one part are really quite different to those that we find in another part. So what do we know about the microbiome? I think I would argue not much. I mean, we've not really been describing it for much more than about 20 years or so. We actually probably know more about the gut microbiome than anything else. We do know a little bit about skin. We know a little bit about the respiratory microbiome, but actually I think it's the gut microbiome that has probably been studied most, probably because it's most easy to get some of that stuff out. I think we probably know a little bit more about disease. And I would argue that actually what we mainly know is associations rather than cause and effect. And I'm not always sure it's easy to work out which came first. Was it the egg or was it the chicken? Was it the cause or was it the effect? Or is it the other way around? I'm not sure we know that. So let's look at normal first of all. We know that in neonates, a caesarean section, which of course circumvents vaginal birth, we know that a significant use of antibiotics, and we know that an extreme diet is associated with a risk of allergy. I was learning yesterday that actually the maternal microbiome may well affect the microbiome of the fetus. I think that might be slightly controversial, but there are, I think, increasing data to suggest that there are elements of maternal microbiome that may have an effect on the developing fetus, and therefore, from our perspective, on the immune system of the fetus. We know, and it's not a surprise because it's been around for several thousands of years, that positive effects of childhood breastfeeding, that children who are breastfed have less allergy, generally speaking, and less autoimmunity, and a large part of that effect is probably due to these human milk oligosaccharides, which have an important impact on the microbiome and on the immune system. This was a paper, Chris Stewart And what they've basically found is that breast milk is a good thing for preterm infants. I said to him, I mean, it's great that you spent all this money and done all this research, but I think we kind of knew that anyway. I think what he's demonstrated is perhaps why breast milk might be a good thing for preterm infants. And these particularly human milk oligosaccharides have important impacts on the barrier function of the gut. They can actually change gene expression within the gut epithelia, and that can lead to changes in the immune response Th1 and Th2 balance. Actually, the human microbiome is not static. It changes with age, and again, that is perhaps not a surprise, partly due to exposure, and I guess partly due to, exposure of other microbes, but also general environment. A lot of the work that's been done in Newcastle has demonstrated different microbiotal patterns associated with necrotizing enterocolitis, which I think essentially is an inflammatory disease, and I think that's what some of these data now show. But again, actually, what we're looking at is cause and effect, or effect and cause. So we know that if you look at the microbiota patterns of preterm infants with necrotizing enterocolitis on one of these graphs, which is a sort of graph that we use when we're looking at the diverse microbial patterns, that pattern looks quite different from infants that do not have necrotizing enterocolitis. So these are preterm infants that don't have necrotizing enterocolitis, and these are preterm infants that do. So we can see a pattern that is different, and some of that pattern relates to some of the things that Chris was talking about in the paper that I've just shown in terms of bifidobacteria, lactobacilli, and the human milk oligosaccharides that are important for that. But I'm not sure we can necessarily say why that particular pattern leads to one thing or the other, or in fact why some infants get that pattern and others don't. We do know that antibiotic use in children who are less than 2 years of age leads to an association with a lower vaccine-induced antibody level to a number of different vaccines. This was just published recently, and I think needs to be confirmed in other studies. But again, if we think back to first principles and believe that the microbiota might be important for influencing our immune response, knowing that children who've had significant amounts of antibiotics and therefore maybe are altering particularly their gut microbiome, it's perhaps not a surprise that we can find that that might have an effect on an immune readout that we can understand. So what about inborn errors of immunity, primary immunodeficiency as we used to know it? Well, I think it's quite complicated because not only do we have to think about the microbiome, but we might need to think about the molecular defect and how that causes a perturbation of the immune system. Of course, many of these patients, infants and older children, and indeed adults, are going to be using antimicrobials, either frequent courses of treatment or indeed of prophylaxis. And that, of course, is going to change some of the readout that we see. and that we might find a different feeding pattern. So we've just been in clinic where we've seen a patient from Thessaloniki who we transplanted in Newcastle 3 years ago with IPEX syndrome, immune dysregulation, polyendocrinopathy and enteropathy. It's X-linked. And these infants don't tolerate milk. They're also on immunosuppression, and they may also be on prophylactic antimicrobials. And so trying to work out what a normal microbiome might be in an infant that has got inflammation, that doesn't tolerate enteral feeding, and is on antibiotics is actually quite difficult. It's this balance again of cause and effect. And clearly there is a molecular defect that leads to a lack of regulatory T cells that leads to the clinical picture that we see. And that changes the microbiome, but it's difficult to know whether the microbiome is changed because of the disease or because of what we're doing, or indeed both, which is perhaps likely. So we actually did a study a few years ago now where we collected poo from 3 infants with severe combined immune deficiency. And what we were interested in, it was a pilot study, which unfortunately hasn't gone any further yet, just looking to see if we could find patterns in the poo germs and whether they changed through the transplant process. So we weren't asking a particularly difficult question. People have demonstrated what a normal microbiota looks like in a normal infant, and we wanted to see what it looked like in a SCID infant. And you can see the infants here. We've got a child at the top with X-linked severe combined immune deficiency, who was 34 weeks old when they came to us. So they will have had a number of infections. They will have had a number of treatment courses of antibiotics. And by the time they got to us, they're probably just starting immunoglobulin replacement, but they will have had low antibody levels because they will have lost their antibody through natural decay that was maternally acquired. And we may also have started just some prophylactic antibiotics. We then have 2 infants who were diagnosed probably because of family history, who were admitted very early. But one of the first things we do when we hear that there is an infant just born with SCID from a family that we know is we say, start prophylactic antibiotics. So even these very young infants will already have been on prophylactic antibiotics. They will actually have had some probably maternal immunoglobulin around from that placental transfer because it's not had an opportunity to decay yet. And you can see that 2 of them had conditioning, 1 of them didn't. They had different donors. They had different nutrition. This was breastfed, at least partly, and this one partly. And they also had different complications, including, I think, skin grade 1 GVHD probably is less important, although maybe from a microbiota perspective it's not as trivial as we think, and skin grade 2 is perhaps a bit more important. But you can see also a line infection, CMV infection, and a fungal chest infection. So what did we see? Well, we were able to group those samples using a similar sort of graph to the one I showed you previously into a pattern that we could identify pre-transplant and a pattern that we could identify post-transplant. And looking at a sort of colour readout, we were able to see that there were different patterns pre-transplant in the different infants of different families of bacteria, and that post-transplant, and transplant is indicated by this dotted pale blue line here, that there were changes after that. We then actually looked not just at what bacteria were around, but what genes did they have and what was the function of those genes, and we were able to again separate these into a pre-transplant pattern and a post-transplant pattern. If you look at a colour readout of the broad family types, it looks like that. And when we look at the gene function, you can see again that there are changes over time and that the babies are different. So what does that tell us? Well, SCID probably looks different from normal. I don't know what the impact of the disease is, versus the impact of being on antimicrobial prophylaxis, of being on treatment for the infections that they got, actually what was the effect of the chemotherapy conditioning, and what was the effect of feeding. We can clearly see that there were changes pre-transplant and post-transplant, but what does it mean? I have no idea. It clearly means something, but other than the fact that we're able to describe these changes, I think it would be very difficult to say this change means one thing and another change means something else. And I think, largely speaking, we're at that level of knowledge when we're thinking about the microbiota. There's been a bit of work done on Omenn syndrome. Omenn syndrome is normally due to one of Vivian's favourite genes, RAG1 or RAG2. And infants with Omenn syndrome have a form of severe combined immune deficiency, but they're leaky, so they do actually make some T cells. They get this very inflamed phenotype. You find T cell infiltration of skin, gut, liver, spleen, lungs. If you do a biopsy of the skin of this baby, it looks like this, and the pathologist will tell you that it's graft versus host disease. This baby hasn't been transplanted yet. The T cells are autologous T cells, they're not donor T cells. We find a clonal lymphocyte population, so one or two families of T cells that are heavily expanded. B cells are usually absent, NK cells are usually normal. There is an eosinophilia. Patients normally have no immunoglobulin apart from a very high IgE, and they don't make new T cells. When we look for naive T cells, we don't see any. We know these patients have abnormal thymic development. As I say, they have aberrant clonal T cell expansion, and you can see that here. We actually find quite a lot of autoantibodies. This is a normal control. This patient here is a patient with SLE, and I might have left out the Omenn's patient, but the Omenn's patient looks very similar. And we also find abnormal thymic development because the thymus needs T cells going through it to develop normally. We call it thymic T cell crosstalk. And if you don't have a normal population of T cells going through, then you get this thymic perturbation with a lack of central tolerance proteins such as the autoimmune regulator. The group particularly led by Gigi Notarangelo at the NIH and Milan, but others, including clinicians and including our group in Newcastle, have been able to show that there is a role for the gut microbiota in the Omenn syndrome dysregulation. Now again, we are describing patterns. They have developed this mouse model, which is a RAG2 model with that particular mutation, which gives in the mouse an Omenn phenotype. And this particular Omenn syndrome mouse develops inflammatory bowel disease, which affects the whole of the bowel. They were able to demonstrate that the lymphocytes are the cells that induce the disease, because when they took the T cells from these pathological mice and transplanted them into immunocompromised hosts, the immunocompromised hosts also developed inflammatory bowel disease. There was an impairment of oral tolerance, and transferring regulatory T cells into these mice helps improve bowel inflammation. There was a deficiency in IgA, the mucosal immunoglobulin, which we see in humans with Omenn syndrome. And the deficiency meant that there were more bacteria that were absorbed into, or improved the absorption of microbial products into the beyond the gut. There was a concern that the microbiota in these mice contributed to the immunopathology, because when you took that microbiota and put it into the wild-type mouse, you promoted this Th1, Th17 response, which we see in the mice. And interestingly, by giving long-term antibiotics to these mice, you were able to diminish, because you were changing the microbiota, the frequency of cells which were particularly trophic for causing gut inflammation and skin inflammation. And the IgE, which is raised in the mice and in humans, normalized when these patients, when these mice were on antibiotic treatment. They were able to show that there was a difference in the microbiota between the normal mouse and this Omen syndrome mouse. And then in a further paper, which also looked at information from human patients, they were able to demonstrate that the T cells from Omen syndrome expressed a pattern of markers probably induced by the microbiota, which tended to home them to the skin and cause this inflammatory skin problem. And that is an absolute hallmark of Omen syndrome. If you see a baby like that, from my perspective, then Omen syndrome is a likely diagnosis. Mice were found to have high levels of IL-13 and IL-5, as well as humans, suggesting or confirming that this is a Th2-driven disease, but it was more complicated because there was also high levels of these other cytokines in patients, and, as I say, similar results in mouse demonstrated the concept that this isn't actually just a Th2 disease, but it's more broadly an inflammatory disease. And it's quite a complicated paper, and I've referenced it here. You're welcome, if you really want to, either to download it or I've got a copy. But they were able to show preferential homing of T cells to the skin in patients with Omen syndrome. In the mice, they were able to show that when you increased the intestinal inflammation, that worsened the skin inflammation. And they were also able to show a difference in the composition of the skin microbiota between the normal mouse, the wild-type mouse, and the mouse with Omen syndrome. Now, again, I think a lot of this is just pattern, that we see differences in a microbiotal pattern, and we also see, in this case, immunological and phenotypic changes, and it's a little bit difficult to be absolutely certain kind of cause and effect. One of the proposed roles is that you get an alteration of the microbiota in the gut lumen. The IgA is important for preventing microbe absorption or microbial product absorption, and in Omen syndrome, therefore, you get that. That leads to this inflammatory phenotype in the immune cells underneath the gut epithelium, and that can lead, as this paper demonstrated, to peripheral downstream effects of that. Not only inflammation in the gut, but also the skin, and we also see inflammation in other organs as well, including liver, including lung, and actually including potentially the heart as well. So I think that's a pattern that we can see. It's maybe a little difficult to be absolutely certain what means what, but there are clearly changes. People have looked at the Wiskott-Aldrich syndrome, a combined immune deficiency, and found differences in the microbiota of the mouth in patients and normal controls. So patients in the dark lines and normal controls in the light grey lines. And there were some significant differences in that. Again, I don't know what it means. I don't know whether having Wiskott-Aldrich syndrome means that you get this altered pattern of microbiota, or the treatment associated with it might also drive that, or whether an altered microbiotal pattern is a consequence of having Wiskott-Aldrich. I think it's not easy to say. Similarly, in chronic granulomatous disease, we can show that in patients with chronic granulomatous disease and colitis, there is a difference in the microbiome that they have compared to patients with chronic granulomatous disease who don't have colitis. It'd be very interesting, I think, to follow longitudinally particular cohort of patients and see those that develop colitis, whether there are changes in that microbiotal pattern over time. We don't have that. This is a snapshot, if you like, and it shows us that there's a difference in the pattern between one group and another, but I don't know that it necessarily explains what's going on, we just know that there's a difference. We do know that there's a pattern of bacteria which tend to be associated with better outcomes, less inflammation. We also see this in other diseases and also in necrotizing enterocolitis in preterms, for instance. So I think we are aware that there are certain patterns of microbes, of bacteria, and probably the products that they produce that drive an immune response perhaps more in one way rather than in another way. This is another interesting study looking at the oral microbiome in patients with low IgA, and they had a number of different diseases. Here we have a healthy control. Here we have a patient or patients with common variable immunodeficiency who have IgA. Here we have patients with common variable immunodeficiency who don't have any IgA, and here we have patients with X-linked agammaglobulinemia. Now, of course, CVID, I would argue, is at least in part a T-cell mediated disease, and therefore it's not, strictly speaking, just an antibody deficiency. Actually, I don't believe that XLA is also strictly an antibody deficiency, because the BTK protein is important in a number of other cells, including antigen-presenting cells. And so I don't think this is simply showing us an antibody effect, but it may be showing us other effects as well. But there were particular patterns that were more associated with patients developing lung disease than in those that hadn't yet at least developed lung disease. But of course, there are many factors involved in patients developing lung disease. So again, I think it's difficult to be absolutely categorical that one particular pattern that we see causes problems that we see, rather than we can see an association between a pattern and a disease phenotype that we recognise. Similarly, looking at the skin microbiome in patients with different inborn errors of immunity, and we have here a control and a number of patients with Job syndrome. This is autosomal dominant hyper IgE syndrome, and you can see again, I mean, actually there are differences between the controls, but it's probably less diverse a pattern in patients with hyper IgE syndrome. And when we look at different diseases that also cause bad skin inflammation or eczema, DOC8 deficiency, Wiskott-Aldrich syndrome, hyper IgE syndrome, Job syndrome, and atopic dermatitis, we can see differences. And again, I think that's probably all that we can say. It would be difficult to say that this particular pattern that we see causes, but in patients who have these diseases, we see different patterns. Looking specifically at the microbiome in patients with DOC8 deficiency, and this is looking, first of all, in DOC8 deficient patients versus healthy volunteers, bacteria, fungi, phages and eukaryotic viruses that are seen on the skin. And you can see there is a tremendous difference in patients with DOC8 deficiency. And when we look at that virome in more detail, even that probably looks quite abnormal to a healthy control. But again, we're describing what we see, not necessarily what is cause and effect. Likewise, so STAT3 deficiency, this is again hyper IgE, dominant negative STAT3 loss of function or Job syndrome. We can see differences in patients, and this is interesting. So we have healthy controls, and that's tongue and the buccal mucosa. We have patients with Job syndrome who don't have candida here, and we have patients with hyper IgE syndrome who do have candida, and that is a problem of Job syndrome, and not surprisingly, those that have candida have candida. But it dominates, and we can see quite obvious differences in the patterns of these patients. But again, I think we're seeing patterns, and I would be reluctant to kind of say cause and effect there. this was looking at, again, the abundance of different microbes in those that are uninfected with Candida and those that have active Candida. And you can see we looked at earlier at the Candida, but there's also different bacterial species, and there are differences that you can see there as well. So there's a number. I mean, there are actually relatively few primary immunodeficiencies where the microbiome from any site has been described in any detail, and this lists actually many of them. Primary immune deficiencies which affect intestinal homeostasis, and we can see in IPEX or FOXP3 deficiency, IL-10 deficiency, hyper-IgE syndrome also affects gut as well as the skin. SCID, I've described, IgA deficiency, chronic granulomatous disease, leukocyte adhesion deficiency. These can all have an effect on the microbiome that we see in the gut, and that may be associated with particular clinical features. But again, it's an association. I'm not sure it's necessarily a cause and effect. And this slide just summarises how possibly some of those interactions may lead to some of the effects that we see. But I think it's important to note that it is a complex picture, because not only are we talking about the immune defects, but there are other environmental features which are important, and then other physiological factors which may be important as well in the development of inflammation, particularly in older patients. Diet, exercise and body habitus are clearly important in feeding into that. So I want to move on to an iatrogenic disease, because we do know a little bit about that, the gut microbiome and graft versus host disease. And there's a lot of work come out of Sloan Kettering about this. And that group's been able to demonstrate that particular antibiotics are associated with increased risk of mortality from graft versus host disease. This is in big human patient cohorts, so these are data that are of importance to us. And of course, it's probably not the antibiotic that's responsible for the clinical readout that we see, but that the changes in the antibiotic might have on microbiota, which might be gut, but might be other microbial sites as well. They were able to show that the imipenem cilastatin treatment suppresses anaerobic commensals and increases the GVHD severity in mice. And they've previously shown that intestinal bacterial loss of the genus Blauatia from the intestine in humans is associated with an increased mortality from GVHD. And this family of microbes, Blauatia, does seem to confirm benefit in terms of an anti-inflammatory effect in a number of disease states. They were also able to show in mice that treatment with this particular antibiotic combination resulted in the loss of the colonic mucus layer, and you can see that treated with aztreonam here is thicker than the imipenem treated ones, and wondered whether that might therefore lead to impaired intestinal barrier function. And then finally, this was a really interesting paper that I was asked to review from the group in Paris, who looked at a group of patients with severe combined immune deficiency, some of whom had X-linked SCID or JAK3 SCID, and were infused rather than conditioned before transplant. And that's been a debate that's raging, and I'm not going to go into that now, but if you infuse a patient with common gamma chain or JAK3 SCID, you will reconstitute T-cell immunity. But you will only reconstitute T-cell immunity, and they were able to show that there's a particular subset of lymphoid cells, the ILC2 cells, that are missing in these patients. And they studied them many years post-transplant, so more than 10 years post-transplant. And in these patients, they were able to show a decrease in type 2 cytokines, looking at nasal mucosa, a decrease in mucus, and a decrease in the secretory IgA, and that there was evidence of a microbiotal dysbiosis. Now, there are some issues with this, because when they looked at other SCIDs, they didn't see that, but they hadn't actually got any SCIDs with JAK3 or common gamma chain SCID that they had conditioned, and therefore had got full immune reconstitution. So this may not be a disease effect, it may, or not completely a disease effect, but it may rather be an effect of the way we have treated these patients, and treating them differently may not lead to this pattern. I think that's amazing, isn't it? Because we would never have thought, I mean, even 10 years ago, that just the way we treat can lead to this sort of problem. And of course, if we've got a dysbiosis there, and they hadn't looked at other sites, like the gut, but from what I've said, there are associations between a dysbiotic pattern and, for instance, inflammation or autoimmunity or allergy, or potentially even an increased risk of malignancy. And there was a paper looking at ataxia telangiectasia where there were differences in, I think it was mice that they were looking at, in the microbiota and the risk of developing a lymphoma. And so, you know, these patients clearly will need to be followed, because, again, they didn't particularly look at symptoms of these patients, rather just the pattern of the immune response and the microbiota. But actually, what we do to patients may also change a microbial pattern. And that was just a summary slide that I had in my review of this paper, showing that there were defects in mucosal immunity, and importantly, there was this nasopharyngeal dysbiosis, and that may in turn lead to inflammatory disease, to allergy, autoimmunity, and potentially at least some forms of malignancy. But it's a multifactorial thing, because, as I say, you've got your primary disease, you've got your treatment before transplant, you're giving allogeneic cells, which is not a normal thing to do, plus or minus chemoradiotherapy with antimicrobial prophylaxis. You've then got your general genetic background. We get very excited about the particular molecular defect, but of course there's hundreds, or if not thousands, of genes adding to that defect as well, which may also influence what we see in terms of therapeutic response. Diet, pre-existing microbiota diversity, as perhaps I demonstrated with the SCIDs, and then complications from transplant, including graft versus host disease, immunosuppression, which is routine anyway, whether patients are getting enteral or parenteral feeding and what effect that might have, and therefore the result that we read out. So it's actually quite a complicated picture. So what? Who cares? Apart from sad people that get very excited about microbiotal patterns. Well, can we change anything? I guess that's the important thing. Environmental modifications might enable us to modify or to ameliorate clinical effects. And I think that was shown in the rag omens mouse model, that giving antibiotics changed the IgE level in the serum. Which antibiotics do you give? And clearly the GVHD data suggests that some from a microbiotal perspective might be better than others. What about the use of prebiotics or probiotics? And it's a debate I am trying to start in our transplant unit for our transplant patients. We've got a horrible restricted dietary menu that we offer our children, which is meant to be almost sterile, and yet we give them gut leakage because of chemotherapy, so they can leak out E. coli into the blood, and maybe actually filling the gut full of pre or probiotics might at least ameliorate some of those problems. And as I say, diet. But remember, even if we do all that, there is still a host molecular defect, and I'm not entirely clear what effect that defect has on the microbial formation or microbiotal formation. And going back again to that prenatal picture, whether, for instance, a maternal carrier, particularly in X-linked disease, may also influence that picture. So, going back to the beginning, I think in microbiota terms, we're probably here at the beginning, that there is a bit of a black hole. We're beginning to see one or two dots of light, but I think there's a long way to go before we really understand what we're seeing, what it means, and whether we can do anything about that that is going to help us when we think about patient management. So I think the critical role of microbiota is only now being realised, and I do think that we have a limited understanding to date, mainly of gut and skin, although there is a little bit of data on the respiratory microbiome. I think we need a much better understanding of what the impact of those microbial genes and the gene products are. And once we have that understanding, we might be able to apply that to some of the diseases. What is the effect of immune dysfunction on the microbiome, and what is the effect of, that should say, the microbiome on immune dysfunction? And then, as I say, there's these compound effects of the diet, of the antimicrobials that we're giving, and many, many, many other environmental features. And there may be some environmental modifications that may help the clinical condition, and that's kind of a bit of a dichotomy, because clearly antibiotics, looking at that original data on the impact of antibiotics and later development of allergy and autoimmunity, might be detrimental, but actually in immune deficiency they might have a beneficial impact on some of those microbiotal changes that we've seen. So I think it's probably fair to end with yet another famous Greek philosopher, which is Aristotle. The more you know that you don't know. I think that's a sign of wisdom, actually, that you realise you don't know anything rather than you think you know everything. I think as the days go by, as each day goes by, I realise I know much and much less about very little at all. So I'm going to leave it there. Thank you very much for your attention, and I would be happy to take easy questions, but no hard ones, please.